doesn't have, so there's 2 out of 3. Active hip extension, pain with squatting, he doesn't really, right? These clinical prediction rules are statistically very sound, clinically sometimes are crap, because they don't make sense. It's almost like you throw a bunch of stuff in and statistically figure out what's related, but it doesn't replace your clinical reasoning or skills, all right? Now, obviously, if somebody has a hip scour, so hip osteoarthritis, what do you think somebody with hip osteoarthritis has? What do they look like? You examine them, what do you expect to find? Decreased motion. What?
Stuck hip flexion contracture.
Hip flexion contracture, maybe, yeah. Some weakness of, yeah, it could be any of the muscles, disuse, atrophy, but especially glute med, glute max. What else? Anything?
Didn't your slide say something about how often they have weak knee extensors?
Yeah, weak quadriceps.
So,
Yep, probably weak quadriceps too. Yeah, so you see that, you say, yeah, probably all of that adds up to you probably have hip arthritis, okay? And then, an x-ray will show changes, but clinically they have hip arthritis. So how can you treat it? Motion, strengthening,
Aerobic exercise.
exercise, yeah, it's all the stuff you just found, right? You fix the impaired mobility, whatever you can, you fix this strength, what you can, you get them active, you have less symptoms, doesn't maybe change what the x-ray shows, but you don't treat it, the x-ray, right? You treat the person.
Do you see those same benefits of walking that you see with knee OA as well?
Yeah, in hip OA, unless there's a lot of abnormality in gait. So walking in a bad gait pattern might
That'd be the same way for
make
the knee
it
though,
worse.
right?
Yeah, yeah. In general, yes, it's well tolerated. But if you have a Trendelenburg and keep walking on it, it's gonna make it worse.
But if you're addressing those impairments of limited range of motion and limited strength, hopefully those gait impairments go away as well, so you might have to train that.
Yep. All right, so Scour, Faber, can you scroll down just to the top of the next Faber? Keep going.
There's a question on what are we looking for with Faber and Faber?
So both of them can be provocative and range, okay? So Faber in hip OA, that can provoke lateral hip pain, okay, here. In impingement, it can give you groin pain. Femoral acetabular impingement. Hip OA, it's usually lateral. And we're looking at the range, okay, so that's obviously limited, okay? Fader, or flexion, adduction, internal rotation, is considered a test for impingement, femoral acetabular impingement, and just coming right up into it.
You're saying in Faber, your abductors are tight and your external rotators are tight?
Your external rotation is limited, yeah. Now, it could be just a combination of things, not necessarily your abductors are tight, you'd have to check, or abduction is limited. His abduction is a little bit limited from what I would expect to have. I mean, that's about it. What do you think that is? 30, 40? So maybe a little bit limited.
Dr. Stoneman, you said Faber is used to assess his impingement, right? And you said you probably would do that on him because it would cause symptoms?
I already know he has symptoms, just in one plane.
So does that mean you suspect impingement?
Mm-hmm.
Okay.
Yep.
Okay,
I suspect some femoral acetabular impingement with him because when I close that motion, he gets this groin pain.
And we know that he's compensated for it, at least on his bike, by just trying to keep those knees out and feet in,
Yeah.
heels in.
And when we checked his posture, he has a very large anterior pelvic tilt, which we'll mess with in a minute. So if we have the hip, the femur as the floor, the acetabulum as the roof, his roof is tilted down, it's gonna give him less room.
Trevor, are you just a mountain biker or do you road bike?
No, I ride on the road quite a bit.
Do you use aero bars?
I have, but not really.
Why not?
I don't like a super low position.
Does it give you hip pain?
Yeah.
Right, so if he's down, coming out this way doesn't work for him anymore, so he has to stay upright a little more.
Even my road setup's like pretty flat.
I was just gonna say, could you have him push in pelvic tilt as you go into hip flexion and see if that makes a difference?
Yeah, it does. It's really hard to do. We can passively position him, so if here's his normal flexion, there's where he tightens up, so you measure it, okay? All right? And then I drive him into a posterior pelvic tilt on this side and take him into flexion. Right there?
Yeah.
Okay. Versus there. Then if I give him a tilt, it doesn't change a ton. I would have expected more. But it's hard to put him in a tilt. So we'll do that in a minute. Okay?
Are the cam or pincer types of impingement the only kinds of impingement in the hip, or?
Cam or pincer or combinations thereof.
Okay.
Yeah, we'll show some pictures.
It's gonna be bony impingement either way, there's not gonna be anything else.
Bony or labrum.
Okay.
Which, okay, can you sit up?
Do we care which one it is at that point?
No, not really. Well, actually, we don't, the surgeon probably does. It depends, is he going to do a pure labral procedure, or is he gonna do some bony
We're gonna be more
procedure?
helping compensate rather than fix
Right.
either one of those.
Either one of those, we're not gonna, which, with Dr. Pratzing, we're leaning, we gotta do something about this anterior pelvic tilt to hopefully give him more room. If we bring the roof up, maybe he can get a little more functional hip flexion. Okay, can you stand up for me? Okay, and then just sit right on the edge of the table there, good. And then just lay back. Okay, now this, the Thomas test you've already learned, but I would say, let's fine tune it a little bit. Can you grab this knee and just hold it there, arm's length. So arm's length is usually fairly close to neutral. You know, I mean, given different arms and different trunk lengths, but, so if I palpate here, that's pretty neutral for him. I haven't pulled him into a complete posterior pelvic tilt. That make sense? But he's not in that anterior pelvic tilt either. And now I'm just gonna relax, let this leg come down. Okay. So not bad. But, okay. Right there, hold that right there. Any pain with that?
No.
Okay, so right there he starts to tilt. Okay, all right, relax. Okay, hold that, no, good. Let this come down, relax it. Yeah, let me hold you like that. So his iliopsoas is just a little tight, but not bad. It's not really pulling, driving that anterior pelvic tilt. Okay, go this one, hold this one for me. Right there. So that's the Thomas test. You see, he's got maybe a little bit of rectus tightness right there, but not bad. little bit of iliopsoas tightness or capsule, and some rectus right there. 'Cause it see that pop up right there. Not too bad. Not finding any easy fixes with you.
On that right side, he kept it, well, I guess on the left side, he kept his hip pretty neutral, but when he dropped his right leg, you had to give him a posterior pelvic tilt. So you think there's a lot of mobility in that SI joint that allows one to tilt while the other one stays
I don't
neutral,
know
or
if
is
it's
that-
SI or lumbar.
Okay.
Yeah, I think.
Could just be some, it rotated in line.
Yeah, I think lumbar stability is important for him. Now, see, right there is really, right there is his true, and that isn't zero. Okay, he has a little bit of hip flexion limitation there, cause there's his pelvic tilt, you see that? So if I don't let his pelvis tilt, there's his range, okay? Then if I come up here, come down again with the rectus slacked out, it's still right there. So it's either capsule or iliopsoas. All right, so that's Thomas test. Can you slide up there? We'll look at hamstring, 90-90. So it's hamstrings that are a little tight, but. What? Not Logan tight, what you said? It's not, what I'd say is, but that's your most reproducible or reliable way to measure is 90-90. Just take the hip to 90, then extend the knee to where you get that resistance. Okay, could I take him more? Yeah, but it's not reliable, okay? So that's the most reliable setup for hamstring. Okay, Thomas, hamstring length. What do we wanna do? Yeah, I think we should. We'll do you wanna go through the SI provocative test, just to introduce them now, to screen them? Cause we really need to, I don't think we can, so, like I said, that lumbo hip pelvic hip complex, he could have he definitely got some asymmetry in his pelvis that could be really related to a sacroiliac dysfunction. There are some screening tests that are pretty good for at least saying, yeah, SI seems to be a source of some of these problems. And Dr. Wilkinson is gonna teach, I think you're still gonna teach SI, right? Okay. So we'll take you through the screening right now, because with him, it'd be important to know, is some of this coming from a sacroiliac problem?